Hi guys, welcome to this second discussion on neuropath and CNS tumors. If you haven't watched the first discussion, please do check it out for a better understanding. The link is in the description. So we'll start up with the second most important tumor, the meningioma. So meningiomas are usually benign tumors that arise from the meningothelial cells, particularly the arachnoid cap cell. So we know the meninges has three layers, the dura, arachnoid and pia. And meningiomas are tumors that arise from the arachnoid cap cells or the arachnoid layer. They are usually seen between the second to sixth decade of life. So that's from 20 years to 60 years. They are slightly more common in females and they are commonly found in the lateral cerebral convexities or along the midline attached to the falx cerebri, which is again made of the meninges. They are usually solitary masses they are usually a solitary mass that is firmly attached to the meninges. They are usually well circumscribed and compress the brain tissue that underlies it. So we know it's well circumscribed and it doesn't invade because it's not malignant. So it just compresses the brain tissue that underlies it, and they can easily be separated from the brain tissue. This is something you have to remember because it really differentiates something that is malignant and benign. So it is well circumscribed, solitary most of the times, and can easily be separated from the brain tissue that underlies it. Two important points to remember which can come as high yield points. One is that these are more common in females because they express estrogen receptors. So there are very few tumors that express estrogen receptors, especially when it comes to CNS. So meningioma is one of those tumors that express estrogen receptors, and therefore they are more common in females. The second little trivia that we know is if you ever see multiple meningiomas, you should always suspect a syndrome called von Recklinghausen syndrome. Okay, so von Recklinghausen syndrome should be suspected when multiple meningiomas are in question. Now let's look at the gross features again, because we discussed it, but it's always important to see pictures so that it has an impact on your mind. Patho is all about pictures. So the first picture shows clearly a well circumscribed mass, again solitary, at the cerebral convexity and compressing the brain tissue that underlies it. The second picture I've included to show you that these masses are firmly attached to the meninges. Okay, so they are firmly adherent to the meningeal layers. This is the meningeal layer, okay, and this is firmly adherent to the meninges. And if you look here, you can see the impact that it had due to its compression. Okay, so again, both of them were in the cerebral convexities. Now we'll talk a little about the imaging. So these are MRIs, okay, and here you can see again it's a well circumscribed mass at the cerebral convexities. Here too, well circumscribed mass, and here you can make out that the tumor is actually compressing the brain tissue and not invading it. And how do you make that out? You can see this small black area between the tumor and the brain, so that helps you realize that it's not invading. Okay, so again, well circumscribed mass, convexities. So this picture I've included because you can get confused and assume that this tumor is invading, but this is actually a photo or an imaging study of a large meningioma. A very large meningioma looks malignant, but if you look closely, you'll notice that there's a black region around this normal brain tissue and this tumor, therefore again indicating that it's actually compressing the brain tissue. Okay, so that was the gross and imaging. Now let's come to the histopathology. So in the histopathology, there's only two things you have to remember. Just two things. The first point is you have spindle-shaped cells with elongated nuclei that are present in a characteristic whorled pattern. So that's all. Just two things you have to remember. The first thing is what you see in the picture. You have these spindle-shaped cells, okay, which are beautifully arranged like this in whorls, right? You can see them in whorls. And the second thing you have to know is this is one of those tumors in which you have Schwannoma bodies. So what are Schwannoma bodies? Schwannoma bodies are nothing but basophilic, that means purple, concentric regions which contain calcium. Dystrophy, due to which the calcium is deposited. So they are basophilic concentric regions which contain calcium. and there are only few tumors that have these Schwannoma bodies, so it's important to know them. So there are 5 tumors that contain Schwannoma bodies, so we'll just outline them in a little bit of detail. Okay, so the first, because this is high yield again, so the first tumor where you see Schwannoma bodies is the papillary carcinoma of thyroid. The second tumor is a papillary carcinoma variant or papillary variant of renal cell carcinoma. The third tumor is meningioma, which we are talking about. The fourth tumor is mesothelioma, and the fifth tumor is the serous cystadenocarcinoma of ovary. So remember, there are two papillaries, papillary carcinoma thyroid and papillary renal cell. There are 2 with M, meningioma and mesothelioma. And lastly, there's the ovarian tumor, serous cystadenocarcinoma of ovary. So this is where you see Schwannoma bodies. So these are just the 2 points that you should know about the histology of meningioma from a NEET point of view. But if there are any second years watching this, you should also know that there are 5 histological variants of meningioma. 5 histological variants. So the first one is the most common classical one, which is the meningothelial variant. The second one is called the fibrous variant. The third one is called the transitional variant. The fourth one is called the angioblastic variant. Okay, and the fifth one is the anaplastic variant, which is nothing but the malignant melanoma. Okay, so the very rare. So easy way to remember them, think of all the cells found in the meningeal layers. So you have meningothelial cells in the meninges, you have fibrous tissue everywhere, so you have fibrous tissue in the meninges, and you have blood vessels everywhere, so you have blood vessels in the meninges. So each of these can give rise to a tumor, and those are the histological variants. So if they come from the meningothelial cells, they are called meningothelial variant. If they arise from the fibrous tissue, it's called the fibrous variant. If there are both meningothelial and fibrous components to the tumor, it's called transitional variant. Transitional means, both are included. If they arise from the blood vessels or the angioblastic cells, it's called the angioblastic variant. And if there is a malignant change in this, which can be visualized on histopathology, then you have the anaplastic variant of meningioma. So that was all about meningioma. Very important topic, easy topic. Okay, and we discussed it in fairly good enough detail for both university exam and NEET. So those 2 astrocytoma meningioma were the most important tumors. Now we'll talk about the rest of the tumors which can also be asked. So the third tumor we'll talk about is the schwannoma. So like we said earlier, Schwann cells are those cells responsible for myelinating the cranial nerves, spinal nerves and peripheral nerves. So what is a schwannoma? It is a benign slow growing tumor of the Schwann cells. Okay, it's benign, most important word, and a slow growing tumor of the Schwann cells. They usually affect the cranial nerves, spinal roots and peripheral nerves. Like we said, Schwann cells are associated with these nerves and therefore they originate there. And why schwannoma is very important is because it is frequently associated with the 8th nerve to form something called a vestibular schwannoma. So a vestibular schwannoma is a type of schwannoma which is seen in association with the 8th cranial nerve, particularly the vestibular component of the 8th cranial nerve. So this is a question that's frequently asked in NEET: from which cranial nerve does schwannoma arise? A, cochlear component of 8th cranial nerve, B, vestibular component of 8th cranial nerve, C and D would be some other cranial nerves, but remember it actually arises from the vestibular component, and it has another name called acoustic neuroma, which most people remember it by, but I would suggest remembering this tumor as vestibular schwannoma because it arises from the vestibular component. Why is this tumor important? Because it's a CP angle tumor which is very difficult to access from a neurosurgical point of view, and by CP angle I mean the cerebellopontine angle, very difficult to access for neurosurgeons, and it presents with sensory neural hearing loss and tinnitus. So that's the clinical feature that acoustic neuroma or vestibular schwannoma commonly presents with. Okay, so deafness and ringing sound in the ear. Next, when they are found elsewhere, they are usually firm oval masses and they are very well demarcated because they are benign tumors. Lastly, it's also called neurolemoma. Okay, so that was just an introduction to schwannoma. Here are pictures to seal the deal. So you can see here, looks like a oval firm mass. Okay, and here this is your CP angle tumor or the vestibular schwannoma, which arises from the 8th cranial nerve. So here you have the cerebellopontine angle, and here is your tumor. Okay, so two pictures discussed. You need to know that radiological image, especially for NEET. Now, for the histopathology, 4 points are important. The first point is you have long spindle-shaped cells with elongated nuclei. Again, similar to few of the tumors we discussed earlier. So, spindle-shaped cells with elongated nuclei. This is common, but the next 3 points are very specific to this tumor, and you should make sure you know them well. This tumor has two regions. It has a hypercellular region and a hypocellular region. So hypercellular means there are more cells. So the hypercellular region, or the region with more cells, is called the Antony A region, and the hypocellular region is called the Antony B region. So let's locate them in the diagram. So here, or in the HP image, so here you see a region with lot of cells, and here you see a region with lot of free spaces and very few cells. So this is the Antony A area, and this is the Antony B area. So always remember, A grade students are hyper, they study more, so hypercellular is Antony A. B grade students study slightly less, so hypocellular, or score slightly less, so hypocellular, less cells. So that was first spindle shaped cells. Then they have two regions, Antony A area and Antony B area. The last thing you need to know is there are something called Verroque bodies. Again, this is a direct question in a previous year NEET, where are Verroque bodies found? The answer being schwannoma. So what are these Verroque bodies? They are nothing but these parallel rows of neoplastic cells. So all these neoplastic cells stand in a row or in a line, or they have a palisading arrangement. I told you earlier, palisading means everything standing in a line. So you can see all these cells standing in a line here. So that this region is called a Verroque body. So parallel rows of neoplastic cells is called a Verroque body. So these are the 4 important histopathological points you have to know that is particular to this tumor. So the next tumor we'll talk about is a very important tumor in children, right? It's called the Medulloblastoma. So I told you this is a new tumor of neuronal origin. No tumor of neuronal origin is found in adults, but in children, because neurons are still dividing, especially the neuroectodermal cells, this tumor can be seen in children. So first point, this is a PNET. What is PNET? It is a primitive neuroectodermal tumor, similar to your retinoblastoma, which is also a PNET. So this is a great advantage for all of us. Most of these or medulloblastoma and retinoblastoma have the same features. So most of the histopathological findings and the clinical features, most of the histopathological findings are common between these two tumors because they have the same cell of origin. So it's usually a tumor of the childhood and commonly affects the cerebellum and the fourth ventricle. Again, remember, tumors in children are infratentorial tumors. So what is infratentorial? Cerebellum and fourth ventricle. So again, medulloblastoma is a common tumor in children. In fact, the most common primary tumor in children, and therefore it's commonly seen in the cerebellum and the fourth ventricle. It can present as obstructive hydrocephalus when it obstructs the fourth ventricle, or it can even present as cerebellar ataxia, in which the child has difficulty in walking and in movements because of cerebellar involvement. So remember, this is a very aggressive tumor, so highly aggressive because it's a blast cell tumor, so highly aggressive, highly undifferentiated tumor, but fortunately responds well to radiotherapy. So medulloblastoma is very, very aggressive and very undifferentiated. Remember, any blast tumor, so blastoma, is always poorly differentiated because the blast cells are rapidly dividing, and the job of blast cells is to divide. So a cell with more division potential divides more, so the malignancy becomes more aggressive. But fortunately for us, it is very radiosensitive. So another point you have to remember, which is a nice trivia about medulloblastoma, it's one of those tumors that can spread by CSF. So medulloblastoma can spread via CSF to the spinal cord. So it can spread from the brain, or the cerebellum rather, to the spinal cord via CSF, and this is called drop metastasis. So one of the tumors that can spread via CSF is medulloblastoma. So Let's look at the images. I told you it's commonly seen in the fourth ventricular and cerebellar region. So here you see the scan of a child MRI, and this is the tumor. Again, you can see the tumor here. It's a highly aggressive tumor. Okay, so histopathology, very important. Again, just three things you have to know. The first thing is that it is highly cellular and all features of anaplasia are seen. So the classical anaplasia is seen in the blast cells and in medulloblastoma. Again, hyperchromatic nuclei, reduced NC ratio, hypercellular, pleomorphism, loss of basal polarity, mitotic figures, everything can be seen in this tumor. For NEET PG aspirants, you just need to remember this one phrase, small blue cells. So you have small cells that have such large nucleus, you can't even see the cytoplasm. So they are essentially just blue, they appear just blue. We know that the nucleus is dark staining, so they appear just blue. So small blue cells with all features of anaplasia. The only named thing you have to learn for this tumor is the presence of Homer-right rosettes. So you know rosette is a round structure, photo of which I'll show you a little later. So remember, Homer-right rosettes are seen in this tumor. And what are these Homer-right rosettes? So you have some neuritic process or some blood vessel, neuronal process or some blood vessel, that's nothing but the neurons part, or some blood vessel, and the cells of this tumor go and sit around this blood vessel or neuronal process, and this structure is called a Homer-right rosette. So in this image, it's not zoomed in enough, so we can't really visualize a Homer-right rosette, but we can see the plenty of the small blue cells and the hypercellularity. So I've added this image to show you the Homer-right rosette, and here it is. So you can see here, this is the vessel, and all the cells are crowded around this vessel, or mostly a neuronal process, and you can see all the other features of anaplasia. So that was it for medulloblastoma. Let's talk about the next tumor, oligodendroglioma. So before we start about oligodendroglioma, I just want you to remember one thing, and that is a fried egg. So if you remember fried egg for oligodendroglioma, it's more than enough to remember everything about this, or rather think of oligodendroglioma as an egg. Okay, so firstly, it's a malignant tumor of the oligodendrocytes. We discussed earlier, oligodendrocytes form the white matter, that is, they myelinate the cells of the CNS. Okay, and they're usually involved in frontal lobes and present with seizures. So like I said earlier, it's a tumor of adults. So any tumor of adults is supratentorial. So it's in the convexities or the frontal lobe. Sorry, not convexities, it's in the frontal lobe, particularly in the white matter of the frontal lobe. And this is one of those tumors that shows calcification. On histopathological appearance, this is why I told you to remember the fried egg that I put out here. The cells show a classical fried egg appearance, and there is a chicken wire pattern of capillaries. So remember, oligodendroglioma means egg. So what all is the relevance of egg? Firstly, it shows calcification just like the outside of an egg. Then it's mainly in the white matter, just like the egg has white matter. This grows in white matter. Third, it has a fried egg appearance histopathologically. And fourth, the capillaries show chicken wire pattern. Chicken also related to egg. So let's look at the histopathology. Here we see, you can see the fried egg pattern here with the nucleus and all the there's a vacuolated cytoplasm around the nucleus. So it looks like a fried egg, this being the yolk and this being the vacuolated region being the albumin of the egg. So that is a classical fried egg pattern. And here you see the capillaries, not so classical in this image, but you can see the capillaries forming a fence-like structure. So chicken wire fence pattern. Okay. So the next tumor we'll talk about is the ependymoma. Like we discussed, these arise from the ependymal cells. They are common in children, so therefore they will be infratentorial. And remember that the ependymal cells are the cells that line the ventricle. Therefore, this tumor will grow into the ventricle. So again, ependymoma, malignant tumor of the ependymal cells, usually seen in children, therefore infratentorial, and it usually arises in the fourth ventricle. Infratentorial ventricle is the fourth ventricle. So since they arise from the cells lining the ventricle, they will block the ventricle, commonly present with hydrocephalus. And in adults, it arises if rarely it's seen in adults, and if it arises in adults, it arises supratentorially in the lateral ventricle. One point to remember about this tumor is that it has a high recurrence rate even after surgery and treatment. Now, in histopathology of this, you just need to remember one point, and that is there are perivascular rosettes. So what does that mean? Here I've outlined the vessel, and you can see the cells are arranged around the vessel just like a rosette or a pseudo rosette. So here, this is a rosette. This is what I was talking about. So perivascular rosettes are classical of ependymal cells. So you have first point, malignant ependymal cells usually affecting the fourth ventricle. Second point, they form rosettes, pseudo rosettes or rosettes called ependymal rosettes or perivascular rosettes around the small blood vessels that are present in the tumor. Very easy, ependymoma. That's all we have to discuss about in this. Last tumor we'll talk about is the craniopharyngioma. So remember, craniopharyngioma is a tumor that arises from the epithelial remnants of the Rathke's pouch. So what was Rathke's pouch? Rathke's pouch is that embryological structure that formed the anterior pituitary. Okay, you just need to remember Rathke's pouch formed the anterior pituitary. Very important point other than this about craniopharyngioma is that it is a supratentorial mass in both children and adults. This tumor develops in the sella turcica, that's where the pituitary sits, and it's a supratentorial mass. It commonly presents with headache, could present with loss of peripheral vision. So because it sits in the sella turcica, it can press on the optic chiasma and cause loss of peripheral vision, which is technically called bitemporal hemianopia. So whenever we hear bitemporal hemianopia, we think about pituitary tumors. So let's also consider, if a patient comes with headache and peripheral vision, you should, and peripheral vision loss or bitemporal hemianopia, you should also consider craniopharyngioma. So this tumor is famous for calcification. So remember, if you have to remember just 2 points about craniopharyngioma, the first one is that it develops from the remnants of the Rathke's pouch, and the second, even more important point I feel, is that this tumor shows calcification, and this is very important. We discussed earlier things like oligodendroglioma also show calcification, but the classical tumor that shows calcification, or the tumor that is known to show calcification, is the craniopharyngioma, and it shows so much calcification that it can even be seen on an X-ray. So one of the only brain tumors that can be seen on an X-ray is craniopharyngioma, and just like ependymoma, they have a high recurrence even after resection because those remnants still remain and still proliferate. So before we move on to the craniopharyngioma's histopathology and imaging, just a small word about the Rathke's pouch, which is a high yield topic in itself. So remember that the pituitary gland develops from two places, the base of the brain and the floor of the mouth. So the base of the brain gives out a projection which later becomes the posterior pituitary, and the floor of the mouth gives out a projection which later becomes the anterior pituitary. So remember, this projection from the floor of the mouth, from the roof of the mouth, which becomes the anterior pituitary, is called the Rathke's pouch. So the projection from the roof of the mouth that later becomes the anterior pituitary is called the Rathke's pouch, and it is remnants of this that are present in the sella turcica which later develop into a tumor called the craniopharyngioma. And if you look at the name, you will understand better. It has the word pharyngioma in it, again signifying that this originated from the mouth. So lastly, this is the last image. It's a lateral skull X-ray of a child, and you can see a calcified growth in the sella turcica. So calcified growth, I told you this is one of those tumors that commonly calcifies. So sella turcica. Now that's it for the second years. For the NEET PG aspirants, one more point I'd like to put forward is about the CNS tumors that show calcification. The most important one that shows calcification is the craniopharyngioma. Then you have the oligodendroglioma, I told you, egg, and lastly you have the meningioma. Okay, so that was it for CNS tumors. We have covered all tumors in good detail with photos. Hope all of you have understood and hope this session was useful. Thank you.